Hello, welcome to my talk on the interpretation of VQ scan for chronic thromboembolic pulmonary hypertension. So I think it's quite useful to go through a few definitions before we start. First of all, pulmonary embolism. These are emboli which usually arise from blood clot in the veins. They lodge in and obstruct the pulmonary artery, causing respiratory dysfunction. I think we are all very familiar with pulmonary embolism and we've heard a lot about it already. But it's important to recognize that this is very different from chronic thromboembolic disease, or CTED. This is where thrombus organizes into chronic scars that occlude the pulmonary arteries. CTEPH, or chronic thromboembolic pulmonary hypertension, is when you have chronic thromboembolic disease, which causes increased pulmonary vascular resistance. And that is pulmonary hypertension. And pulmonary hypertension, or PH, is when you have a mean pulmonary artery pressure of more than 20 millimeters of mercury. And that's a very specific definition for pulmonary hypertension. It doesn't suggest the cause for the pulmonary hypertension. It isn't a pathology in of itself. Pulmonary arterial hypertension, however, is a pathology, and it is when you have a pre-capillary pulmonary hypertension in the absence of other causes of pulmonary hypertension, such as CTEPH or pulmonary hypertension associated with lung disease. So essentially, it is a diagnosis of exclusion, and it is a sort of discrete pathological entity and a diagnosis that we are trying to make. So why is it important to categorize the cause of pulmonary hypertension? So pulmonary hypertension is, as we mentioned, essentially where you have raised pulmonary arterial pressure, and there are 5 categories of disease that cause this. The one we're really interested in is CTEPH, or pulmonary hypertension associated with chronic thromboembolic disease. And the other causes are pulmonary arterial hypertension, as I mentioned earlier. That's a rare cause. It's a discrete pathological entity, can be often idiopathic, can be inherited, and there are some other associated conditions with that. The most common causes of pulmonary hypertension are heart disease and parenchymal lung disease. And our purpose of performing VQ scanning is to identify CTEPH. Now, why is that important? Well, the reason is because CTEPH is the only reversible or easily reversible cause for pulmonary hypertension. It is surgically treated, so we can do endarterectomy, we can do balloon angioplasty, and that's the reason we perform the VQ scan, is to identify CTEPH as a cause for pulmonary hypertension. So how do we use VQ scanning in the diagnostic algorithm? Well, if you have a patient who has suggestion of pulmonary hypertension, often that's from an echo where there's suggestion of raised right ventricular pressure or raised pulmonary artery pressure. Then we will look for other causes, more common causes of pulmonary hypertension, first of all, such as heart disease and parenchymal lung disease. If we don't have any other evidence for heart disease or parenchymal lung disease, then that's where the VQ scan comes in. We do the VQ scan as a screening tool for chronic thromboembolic pulmonary hypertension. If it's abnormal and shows mismatched perfusion defects, then we say that actually CTEPH is likely. We would need to compare that with a CT pulmonary angiogram, a right heart cath, and potentially also a pulmonary angiogram. And the reason is because the CT pulmonary angiogram can look for proximal clot, and the pulmonary angiogram can confirm the presence and the extent of the distal disease, which we also get an idea from the VQ scanning. What are the causes of CTEPH? Well, as I mentioned, this is a group 4 cause for primary hypertension. It's characterized by organized thromboembolic material and by altered vascular remodeling that is initiated or potentiated by the combination of defective angiogenesis, impaired fibrinolysis, and endothelial dysfunction. And all this sort of scarring in the vascular system can lead to primary hypertension and ultimately right ventricular failure. It's not really clear what causes CTEPH. Data from the International CTEPH Registry, which includes multiple centers from Europe and Canada, show that 75% of patients with CTEPH had a documented preceding history of acute pulmonary embolism. However, similar data from a registry in Japan shows that only 15 to 33% of patients with CTEPH had a preceding history of acute pulmonary embolism. There's also a little bit of discussion as to whether actually a lot of the patients that are presenting with acute PE initially may actually have already had chronic thromboembolic disease. It's not always clear to make that diagnosis or differentiation of acute versus chronic on imaging. The incidence and prevalence of CTEPH is very low. The incidence is only 2 to 6 cases per million and prevalence of 26 to 38 cases per million. And the incidence of CTEPH after a symptomatic acute pulmonary embolism is reported to range between 0.4 to 6.2%. Interesting, a new report from Switzerland which screened over 500 patients with acute pulmonary embolism over 2 years, they found that actually less than 1%, so 0.79% of patients, actually developed CTEPH as a result of their acute pulmonary embolism. So what we really don't know is why some patients have an acute pulmonary embolus that is treated, but still they develop chronic thromboembolic disease or CTEPH. And we don't know what those factors are, and we don't know what sort of extent of disease causes CTEPH. The pathophysiology of CTEPH is different from acute pulmonary embolism. It's worth looking at. Essentially, you can have disease that affects the small vessels. It affects the pulmonary artery, where you get thrombus and then recanalization. It can affect the arterioles, where you can get thickening of the arterioles, and that's similar to pulmonary arterial hypertension. You can get capillary type lesions, and you can also get lesions affecting the veins, causing fibrosis, similar to PVOD. And on an angiogram, a pulmonary angiogram, you can see how you've got these peripheral small defects that are showing up on the pulmonary angiogram that are similar to what we would see corresponding to a perfusion abnormalities on a VQ scan. So how do we actually diagnose chronic thromboembolic disease on a VQ scan? Well, unfortunately, there's no clear consensus. The difficulty is that we know that when we image patients after they've been treated, often pre-existing defects have resolved or significantly improved. So you can see here on these images, you can see these pulmonary mismatch perfusion defects are definitely less conspicuous over time. And arguably at 4 years, it's only really this one that's still visible. We don't know why some of them resolve and some of them don't resolve. And this causes problems as to sort of when we call it positive. We can't use the EANM criteria for diagnosing acute pulmonary embolism. The other thing that is tricky is that the extent of the perfusion defects don't correlate with CTEPH. So patients can have quite significant pulmonary hypertension and not have such large extent of disease on a VQ scan. But one thing that's really is definite and very useful to bear in mind when you're reporting is that a normal perfusion scan means this patient doesn't have chronic thromboembolic disease, or certainly doesn't have chronic thromboembolic disease that is going to be surgically accessible or surgically treatable. So that's the reason for doing the VQ scan, is to identify if the patient might have surgically accessible chronic thromboembolic disease as a cause for their pulmonary hypertension, and consider that as a treatment. So if you've got a normal perfusion scan, then that's worth excluding that as a diagnosis. When you do have mismatched perfusion scan, then this could represent CTED. However, up to 10% of patients with other causes of pulmonary hypertension, such as pulmonary arterial hypertension or PVOD, can also give you mismatched perfusion defects. So it's not always clear cut to say that if you've got mismatched perfusion defects, this is definitely chronic thromboembolic disease. You have to bear in mind other investigations and looking historically and at the history as well. It's recommended that a perfusion defect involving less than 50% of the bronchopulmonary segment shouldn't be considered as evidence for thromboembolic disease of its own right. I'll show you some cases which will hopefully illustrate the point and the extent of the abnormalities, or the varying abnormalities we can see on a VQ scan. So this is case one, is a 54-year-old woman with a 10-day history of shortness of breath and raised D-dimer. The CTPA is pretty straightforward. You can see these segmental filling defects on the pulmonary angiogram, which are in keeping with acute pulmonary embolus. A year later, the patient was still breathless, and we repeated the CTPA, but unfortunately, actually, as expected, those pulmonary emboli have resolved and are no longer visible. However, we also did a VQ scan, and you can see that there are small subsegmental mismatched perfusion defects here in the right upper lobe, and also here in the left lung base. Now, given the history of previous PE and no other obvious cause for this patient's abnormality on the CT, we would diagnose these as chronic thromboembolic disease. So we would say that these are residual areas of scarring that are the result of the previous PE. This is case two, where you have a patient who has become progressively short of breath on exertion, and now their SATs are at 88% on mild exertion. You can see that there are sort of larger filling defects in the proximal pulmonary circulation, lobar, as well as segmental branches. And a year later, the patient was still short of breath. We just did a VQ scan, and you can see that there are definitely some residual mismatched perfusion defects. You can see probably in the apical segment to the right lower lobe, and then also in the middle lobe, there are these very clear mismatched perfusion defects. So these are larger than on the first case, and these again would be in keeping with chronic thromboembolic disease, because we know the patient has had a previous PE. So there is, these are segmental mismatched defects. These are going to be chronic thromboembolic disease. Case number three, this is a patient who's actually been short of breath on exertion over several weeks. And the CTPA in this case shows some filling defects in the segmental and segmental branches of the pulmonary arteries. But there's also some evidence of recanalization. So some of these thrombi are not occlusive, and there's some recanalization. There's some mural thrombus here. So this is actually potentially someone with chronic thromboembolic disease, or perhaps acute on chronic thromboemboli. The VQ scan in this patient that was done 6 months after their CTPA, after they've been treated and anticoagulated, shows quite extensive mismatched perfusion defects. So you can see on this bottom row here, we've got multiple perfusion defects that are not matched from the ventilation study, and the VQ quotient imaging highlighting those mismatched segments quite clearly. So this is a patient who had perhaps initially diagnosed as acute pulmonary embolism, but perhaps they actually had chronic thromboembolic disease at initial presentation. After 6 months of treatment, there hasn't really been a good improvement or resolution of those perfusion defects, and this patient will now need to be treated for chronic thromboembolic disease. And if they have pulmonary hypertension, then that would be CTEPH. So to summarize, CTED and CTEPH are probably the sequelae of acute pulmonary emboli, although there may be a different origin for some cases. Unfortunately, we can't predict which patients with acute PE will go on to develop CTED or CTEPH. There's a small number of patients will. It's not recommended we do kind of routine screening after treatment for patients with pulmonary emboli to look for evidence of CTED if they're asymptomatic. It is very useful to do a VQ scan in the context of CTED or CTEPH because a normal VQ scan can exclude surgically treatable disease. When you're reporting the VQ scan, look for mismatched segmental defects, but be aware that other causes of pulmonary hypertension can also cause mismatch. We do know that patients with pulmonary arterial hypertension can have this sort of peripheral, small, subsegmental and non-segmental mismatched perfusion defects, and can be difficult to differentiate from chronic thromboembolic disease. So I hope this has been helpful and you've enjoyed this presentation and you enjoy the rest of the sessions today. Thank you.